So hi, welcome. So yeah, the CML's quite a hard talk to give, really, because the thing about CML is a lot of the decisions are very subtle between one person and the next. It's not like, you know, this particular treatment's going to suit this group of people and this particular treatment's going to suit this group. And so I guess I'd just précis the talk by saying that you know, a lot of the information, you know, you might get swung saying, oh, gee, I should be on that drug rather than this drug, or I should be on that drug rather than this drug. And it is very individual now, CML, in terms of which drugs, you know, may be better for you and which drugs may not be. And so, you know, welcome to just take the information away and discuss it with your doctors, but just don't sort of, I guess, don't go away from here thinking you've been put on the wrong thing or you're being treated the wrong way, because there's more than one way to skin a cat. So just in terms of CML, then it's a relatively rare disease. So, you know, the PA hospital is a big hospital. We probably see 4 or 5 new cases of CML a year. The average age is about 50 years, but it's got quite a wide spread. So I've, you know, got patients who present pretty much never in kids. So it's from about age 20 on, but with a wide spread. The majority of people most people these days actually present as just an incidental blood count abnormality when they've gone to the doctor for their flu or for their whatever else. But, you know, a few people do present with fatigue or symptoms of being sort of full early after eating from having a big spleen. And it's a fairly easy diagnosis to make from our point of view. It's sort of it's got a very characteristic blood film abnormality in most people, and then a very characteristic genetic abnormality, as I'll show you. And so it's got increased immature white cells in the blood, and these eosinophils and basophils are just a type of white cell that we use to sort of alert us to the fact that this is probably what we're dealing with. This is just to remind us that this is sort of your blood. So these are your primitive blood cells, your stem cells, and then they sort of divide down and turn into red cells and white cells and platelets. And the sort of the defect in CML isn't just with your white cells. So it's up here a bit further. So it does actually affect your platelets as well. It's quite common to have a high platelet count in CML. The main defect, this is just a blood film abnormality, which, you know, isn't going to mean much, but these just show that these are all white cells, and they're white cells in many different stages of development. And as I said, you know, really it's a pretty easy blood film diagnosis to make. So most of the time we're doing the extra tests to confirm the diagnosis that we're already pretty sure of by the time we've had the blood test. So, that's cool, isn't it? Some of these slides I made a long time ago, and obviously was feeling jaunty when I made that one. This is the characteristic genetic abnormality. So these are your chromosomes. So this is sort of, one of these came from your mum and one from your dad, one from your mum, one from your dad. So that's sort of how we inherit our genetic material. But then through our life we can acquire genetic abnormalities. So these aren't things that we've inherited from our mum and our dad, but at some stage through the life, some of the cells within the bone marrow, one of these guys here has swapped places with one of these guys here. So you've sort of had a switch of part of your chromosome as your cells divided, and that's set up the mutation, which has then led to CML. And what that switch does is it brings this bit of chromosome 22 in conjunction with this little bit of chromosome 9, and you end up with this little chromosome here, which is called the Philadelphia chromosome. So when you're sort of talking about being, you know, Philadelphia positive or following the percentage of Philadelphia cells, it's just counting these. So that's at a sort of chromosomal level. So chromosomes are big clumps of DNA, if you like, but we can get right down to a gene level and see sort of what it does in terms of causing a fusion gene, and that fusion gene causes a specific little protein which basically runs around in the cell and causes problems by stimulating the cell to divide out of control, really. So that's where the leukemia came from. And CML is very different from just about every other cancer in that it seems to be largely just a one-hit disease. So there's one one abnormality, that's you know, one thing that's abnormal, it turns on your disease. If you can turn that off, you turn the disease off, whereas most other cancers have 3, 4, 10, 20 hits that lead to the cancer, and so you might target one of the genetic abnormalities, but it doesn't actually get you any further to actually curing the disease, whereas in CML it seems to. So this is sort of the without treatment, and obviously pretty much everybody gets treatment. So without treatment, CML has a chronic phase, which is, you know, 5 years or so, and then an accelerated phase where it turns a bit nastier and starts to divide a bit more out of control, which usually lasts a period of about 18 months, and then a blast crisis, which is sort of an aggressive acute leukemia and often is pretty hard to treat. So that's really what CML was like as early as sort of probably 15 years ago. So in 1999 we had a few drugs to try and slow this down, but we didn't really have anything that would sort of turn off the disease. So 1998 the first patient in the world got treated with Gleevec, and then there's been other drugs from there as I'll show you. So in the old days with that sort of thing, the average survival was 3 to 5 years. With sort of about 5% of people dying in the first year, you know, 12% in the second year, and then a bit more than 20% every year thereafter. And I guess the only importance of saying this, because obviously we've got treatment now, it's not the bad old days, it's good old days, but the importance of that is that, you know, we do have patients who struggle to comply with the medicine, or, you know, find that they're finding it tough to take the medicine, and I guess this is what we've just got to remind ourselves of. It is a nasty disease if you don't take it seriously. So the SoCal score is sort of an attempt to predict prognosis. It's not that great a thing, but the importance is that it's been around for a long time. It was around before Gleevec and all these other drugs were discovered, and it still seems to hold to some extent in the current era. And so we do sort of try and work out a SoCal score, but a lot of times it's done retrospectively down the track. If, you know, if things aren't going well, then we sort of look back and go, oh, what was your SoCal score? We should have a think about what we're doing now, because it probably doesn't influence us too much in what we're doing up front. As I said, it's very complicated. That's the formula to work it out, but these days you just plug in certain figures into a web page and it sort of spits out the result for you, and it sort of tells you based on somebody's age and spleen size and initial platelet count and blast percentage, the blasts of the immature white cells in the blood. Based on those, then it can sort of give us some idea of whether we can predict that you're more likely to respond to the medicine or less likely to respond to the medicine. So in terms of treatment options then, often when people are first diagnosed, they're treated with hydroxyurea, which is just like a gentle chemotherapy agent that helps to bring the white cells down. It doesn't do anything to the underlying process, so it's sort of just a temporary fix until we get ourselves organised to do something a bit more permanent. Sometimes people have a very high white cell count or a very high platelet count at presentation, and so they actually need to go on a machine to get them sort of skimmed off mechanically. But then other than that, you know, that's really in the initial few days or weeks until we can get ourselves organised to go on more treatment. Interferon on cytarabine, I've just got there because that was sort of the standard of care, if you like, before the current batch of drugs that we've got now. You know, they were quite good drugs in that they did certainly prolong survival and lead to remissions in a number of patients, but really nothing like the drugs we've got now, and with significant side effects. So this is just, it's a very complicated slide, but if you just focus here, so the people who got interferon, 24% fatigue versus 1% on Gleevec, 8% muscle aches on interferon versus 1.5% on Gleevec, and 13% depression versus, you know, not many on Gleevec. So that's data from the initial trial of Gleevec, which actually compared Gleevec to interferon on cytarabine, and so that trial was fairly rapidly terminated because it became clear that Gleevec was just so much better. So you know, we would only really consider using this today in somebody who was totally unable to tolerate any of the others, and or sometimes, as I'll talk about later, we're thinking about using combinations of some of these drugs with some of the other drugs nowadays. Yeah. Who invented Gleevec? So it was a drug company drug. So I can't tell you for sure, but I think it was a Novartis drug at the start, but it may not have been. Anyway, it was drug companies have a bank of hundreds of thousands of drugs often that they've sort of discovered and patented and just put in a bottom drawer somewhere. And there was just a researcher in the States, a guy called Brian Drucker, who sort of just kept working on it in the background and sort of discovered, it was almost incidentally discovered that it sort of appeared to work in some cell lines of Gleevec, and then tried it in a few patients and then sort of went on from there.
From that drug has come other drugs.
That's right. So once they worked out that it looked like it was working, the other drugs are sort of engineered drugs to do much the same thing with slight tweaks.
And what was the idea of Gleevec in the first place? Was it to turn the gene off, or was it to keep the mutation down?
Look, I guess they didn't really know until they tested it. So it was I'll get on to Gleevec in a sec. I'll show you how it works, and then we can sort of talk about how what I don't know what the original idea was behind it, but it was to sort of have a magic bullet, if you like, that switches off the genetic abnormality. Bone marrow, again, before the days of Gleevec, really, if you were young enough to get a bone marrow transplant, then really a bone marrow transplant was the treatment of choice for CML. Not many people are sort of necessarily young enough or have matched donors and things to have a bone marrow transplant, but if you had to pick one disease that transplant works the best in, it's probably CML, but it's still not as good as the other drugs that we've got now, and so that's why it's never really considered as a first-line treatment for people presenting in the chronic phase of the disease. So this is the data sort of for transplant, showing that about 85% or so of people will survive after having a transplant and be generally pretty well. Some of them may need ongoing treatment, but so it's got a very good outcome really in CML. But this data only holds in people who are transplanted within 6 or 12 months of diagnosis. Where they're diagnosed, say, all right, we're going to transplant you, go ahead. And so these days this data doesn't really hold because that doesn't happen to anybody these days. So this is more what happens to people who are transplanted these days. So if you've got good risk disease, as in if you're in chronic phase of CML, still about 70% of people will sort of survive with the transplant. And that's, obviously may be good enough if you've had trouble with your first few lines of therapy, but it's certainly never considered up front and in chronic phase, and rarely considered second line. It's often a third or fourth line treatment. So stem cell transplantation involves chemotherapy and radiotherapy. You're getting somebody else's bone marrow, and so that gives you somebody else's immune system. And the whole idea is that then you hopefully get this graft versus leukemia, where their immune system recognises your leukemia as being foreign and goes to work and attacks it. But the downside is that it also recognises your body as being foreign and goes to work and tries to attack your body as well. And that gives you, and to sort of try and stop that, then you need immune suppressive drugs, and that puts you at risk of infection. And so that's why people who, that's why we can't just sort of slip somebody else's bone marrow into somebody with CML without any complications, and why it's not considered the first line treatment now. No, so there's not really been shown to be any benefit for using your own cells. There are diseases where we do stem cell transplants using your own cells, but they're diseases where really the aim of that is to allow a big whack of chemotherapy that would otherwise wipe out your bone marrow and then sort of slip your own cells back into you to save your bone marrow. Whereas in CML, that's probably not been shown to be of any, of any benefit, and so therefore it's not really considered. Yeah. All right. So then, we move from those sort of other treatments to what is really the main treatment for most people these days with CML, which is one of these TKIs. You'll hear me saying TKI. It's just a sort of a group name for all the different drugs. And so, the tyrosine kinase inhibitors, that's how they work. I'll talk a little bit about that in a sec. But there's these three, and there's actually more than that, but they're the three that are on the market in Australia for CML treatment. So as I said, this was big news when it first came on. So this is the cover of Time from, I think it might be 2001, where, this Gleevec was really the first targeted therapy where it was a therapy that wasn't chemo or radiation. It was a therapy that was specifically designed to sort of try and block this genetic abnormality that causes the disease. And it does that by, so this BCR-ABL is the fusion protein that's caused by the abnormal genetic abnormality, and it just sits in there and basically stops this fusion protein from stimulating things so there's various things that the fusion protein stimulates, but it just stops it stimulating the cell, so therefore the cell doesn't divide out of control. Just sits in that little groove in the fusion protein, which is the groove that sort of the protein uses to activate other proteins.